Welcome to our channel, Medicine A to Z. Today, we will discuss about bronchiectasis. Bronchiectasis is a condition defined by chronic, irreversible, dilatation and distortion of the bronchi caused by infectious and inflammatory destruction of the bronchial wall. Incidence of bronchiectasis. The incidence of bronchiectasis increases with age, with an 8 to 10-fold rise occurring after the age of 60 years. Conversely, bronchiectasis tends to be more prevalent among females. Etiology of bronchiectasis. Diverse etiological factors associate with this condition. Pulmonary infections. Pulmonary infections stand as one of the primary contributors to bronchiectasis. Post-infectious cases range from 20% to 40% worldwide, with distinct regional differences. In developed countries, post-TB cases remain less than 2%, whereas they emerge as the dominant cause in regions like East Europe and Asia. A significant percentage, ranging from 20% to 60%, falls under the idiopathic category, varying in prevalence across different regions. Additionally, other lung diseases such as COPD contribute approximately 7%, while asthma accounts for 5.2%. Allergic bronchopulmonary aspergillosis ranges from 1% to 10%, and cystic fibrosis is observed in less than 1% of cases. Defects in host defenses play a role in bronchiectasis. These include local factors such as primary ciliary dyskinesia and systemic factors, including hypogammaglobulinemia and leukocyte dysfunction, each accounting for less than 5%. Autoimmune conditions contribute to 1% to 10% of bronchiectasis cases, encompassing rheumatoid arthritis, Sjogren's syndrome, and ulcerative colitis. Rare syndromes like Young syndrome and yellow nail syndrome each account for less than 1% of cases. Additionally, genetic disorders like alpha-1 antitrypsin deficiency and Cartaginer syndrome are notable factors. Anatomical defects, including tracheomalacia or William Campbell syndrome, tracheomegaly or Meunier-Kuhn syndrome, and bronchomalacia, contribute to less than 1% of cases. Bronchial obstructions, whether foreign bodies such as popcorn or seeds, intraluminal factors like carcinoma or mucus impaction, or extraluminal compression due to lymphadenopathy, can lead to bronchiectasis. Foreign bodies usually lodge right side lower lobe or posterior segment of the upper lobe. Understanding the varied etiologies of bronchiectasis is crucial for tailored treatment approaches and emphasizes the need for comprehensive evaluation in clinical practice. The pathophysiology of bronchiectasis is commonly characterized by distinct phases involving infection and chronic inflammation. The interplay between these phases sets forth a detrimental cycle culminating in the destruction of the bronchi. Infection triggers inflammation, leading to the formation of exudate and subsequent destruction of the bronchial walls. This exudate obstructs the bronchi, fostering an environment conducive to further infections. The initiation of this cycle varies, as it can commence from infection, inflammation, or obstruction. Exploring these entry points for each etiology separately allows a comprehensive understanding of how the cycle is initiated. However, it's important to note that the pathophysiology of certain etiologies remains uncertain. Conditions like yellow nail syndrome and specific autoimmune disorders such as rheumatoid arthritis, Sjogren's syndrome, and ulcerative colitis pose challenges in elucidating their precise mechanisms about bronchiectasis. In certain etiologies of bronchiectasis, such as post-infections and post-tuberculosis cases, along with specific immunodeficient conditions like hypogammaglobulinemia and prolonged immunosuppression, the entry point often begins with an infective insult. Following these initial infections, the lungs undergo structural damage, paving the way for the establishment of bronchiectasis. Post-infections, notably severe respiratory infections or conditions like tuberculosis, set the stage for chronic inflammation and subsequent bronchial damage. Similarly, in cases of immunodeficient conditions, such as hypogammaglobulinemia or prolonged immunosuppression, the compromised immune response leaves the lungs vulnerable to recurrent infections, initiating the cycle leading to bronchiectasis. In certain etiologies of bronchiectasis, such as allergic bronchopulmonary aspergillosis, ABPA, asthma, and alpha-1 antitrypsin deficiency, chronic inflammation serves as a key entry point in the pathophysiology. ABPA, characterized by an exaggerated immune response to Aspergillus antigens, leads to persistent inflammation within the bronchial passages. Alpha-1 antitrypsin deficiency, a genetic condition, leads to chronic inflammation due to the unopposed action of neutrophil elasticity. Alpha-1 antitrypsin serves as a regulator, acting as a natural inhibitor to neutrophil elastase. Deficiency in alpha-1 antitrypsin allows the uncontrolled activity of neutrophil elastase, contributing to persistent inflammation in the bronchi. Foreign bodies, such as inhaled objects, tumors, or mucus impaction, can act as initiators by obstructing the airways. Conditions like cystic fibrosis, characterized by thick and sticky mucus, and primary ciliary dyskinesia, a disorder affecting cilia movement, also contribute to airway obstruction. These obstructions create an environment conducive to infection, leading to inflammation and subsequent bronchial damage, thus perpetuating the cycle of bronchiectasis. Bronchiectasis manifests with a range of symptoms and signs, which are essential in its clinical assessment. The most prevalent symptoms observed in bronchiectasis include cough, reported in approximately 98% of cases, is often persistent and productive. Sputum production affects around 78% of individuals. Dyspnea, or shortness of breath, is observed in about 62% of patients. Hemoptysis, or coughing up blood, noted in approximately 56% of cases. These symptoms may vary in intensity and frequency among individuals with bronchiectasis. Upon clinical examination, several signs might be evident. Crackles in the lungs were detected in about 75% of patients, indicating abnormal breath sounds during auscultation. Wheezing is present in approximately 22% of cases, indicating airway obstruction or narrowing. Clubbing of fingers or toes, seen in around 2% of individuals, suggesting chronic hypoxia and tissue oxygen deprivation. The diagnosis of bronchiectasis relies on a combination of clinical evaluation and HRCT. HRCT findings provide crucial insights, including specific features indicative of bronchiectasis. These findings on HRCT commonly include airway to artery ratio greater than 1.5, signifying bronchial dilation compared to the accompanying pulmonary artery. Lack of tapering in the airways, presenting as a tramline appearance, indicative of bronchial dilation extending to the periphery of the lungs. Visibility of airways, measuring less than 1 centimeter from the costal pleural margin. The causes of bronchiectasis often correlate with specific patterns of lung involvement observed in HRCT. Focal lung involvement, characterized by localized lesions, can be attributed to foreign body aspiration or tumors causing focal obstructions, lymphadenopathy, leading to localized airway compression. In cases of diffuse lung involvement with central predominance, bronchiectasis may result from conditions such as allergic bronchopulmonary aspergillosis, ABPA, Meunier-Kuhn syndrome, William Campbell syndrome. Upper lobe involvement is seen in cystic fibrosis, sarcoidosis, tuberculosis, and post-radiation bronchiectasis. Lower lobe involvement observed in idiopathic bronchiectasis, post-infective bronchiectasis, and immunodeficiency conditions. Notably, right side middle lobe involvement is linked to non-tuberculous mycobacterial infections, emphasizing regional specificity in causative factors. Understanding the association between lung involvement patterns in HRCT and the diverse causes of bronchiectasis is crucial in directing diagnostic investigations. Specific investigations for etiological diagnosis of bronchiectasis. For suspected foreign body aspiration or tumors as potential causes. Flexible bronchoscopy serves as a crucial diagnostic tool, allowing direct visualization. When Healer lymphadenopathy suggests conditions like TB, sarcoidosis, or histoplasmosis, mediastinoscopy and biopsy offer a more definitive assessment. In cases suspected of cystic fibrosis, sweat chloride testing and genetic testing aid in confirming the diagnosis by assessing chloride levels in sweat and identifying specific genetic mutations associated with cystic fibrosis. For suspected primary ciliary dyskinesia, nasal nitric oxide measurement and extended panel genetic testing are used to identify abnormalities in ciliary function and genetic mutations related to this condition. In cases associated with immunodeficiency disorders like IgA, IgG deficiency, or hypergamma-globulinemia, quantitative immunoglobulin levels, neutrophil counts, and specific antibody testing provide valuable insights into immune system function and potential deficiencies. For suspected alpha-1 antitrypsin deficiency, assessments involve measuring serum levels and genotyping for alpha-1 antitrypsin, aiding in confirming this genetic disorder. In cases linked to rheumatic diseases, testing for specific autoantibodies like rheumatoid factor, anti-ESA, and anti-SSB helps in identifying potential rheumatic conditions. Diagnosing Young syndrome involves assessing sperm count to identify obstructive azoospermia, a characteristic feature of this rare condition. Management of bronchiectasis. Educating patients about their condition is crucial. Knowledge empowers. General measures play a significant role. Vaccination against pneumococcal infection aids in preventing complications. Smoking cessation reduces airway irritation and exacerbations. Maintaining a healthy weight supports overall health and reduces strain on the respiratory system. Airway clearance techniques are vital. Chest physiotherapy and pulmonary rehabilitation help in clearing secretions. Hypertonic saline nebulization aids in mucus clearance. Antibiotic prophylaxis is recommended for frequent exacerbators. Azithromycin is often prescribed, 500 mg 3 times per week or 250 mg daily. Eradication of specific organisms like Pseudomonas aeruginosa involves intravenous antibiotics for 2 weeks, followed by nebulization for 3 months. Surgical resection is considered for refractory or life-threatening cases. Surgical intervention is opted for localized, recurrent, or life-threatening hemoptysis. Cystic fibrosis management involves CFTR modulation. Immune deficiencies require replacement immunoglobulin. Allergic bronchopulmonary aspergillosis, ABP, necessitates steroid and antifungal therapy. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.